Good afternoon, respected chairperson and esteemed faculty. I'm Dr. Ankit Shashank Gandhi, second year radiology resident at Krishna Vishwavidya Pitfalls. Today, I'll be presenting my paper on topic role of CT imaging in early identification of complications in acute pancreatitis, patterns, pitfalls, and reporting checklists. Coming to introduction, acute pancreatitis is a fairly common abdominal emergency that can lead to severe complications that include necrosis, vascular thrombosis, fluid collections, and organ failure. Early identification of these complications through CT imaging is critical to guide treatment decisions and reduce morbidity and mortality. However, subtle early findings can be missed or misinterpreted, delaying the management. This paper emphasizes the role of CT in recognizing the complications at an early stage, highlights common pitfalls in interpretation, and proposes a structured reporting checklist to ensure comprehensive evaluation. Coming to methods, analysis of total number of 11 patients with acute pancreatitis who developed complications with the first week of presentation was performed retrospectively. Multiphasic contrast enhanced CT scans were reviewed for early imaging signs suggestive of complications, potential diagnostic pitfalls, and structured reporting practices. Imaging findings and complications were correlated with clinical history, laboratory values, and outcomes to assess the utility of early recognition. Coming to the first case, a 37-year-old male patient came with chief complaints of pain and abdomen, leading to the back, and 3 to 4 episodes of vomiting since 2 days. Serum lipase, amylase, and CRP values were raised. CCT imaging findings were as follows. There's evidence of peripancreatic fluid collection, seen extending anteriorly up to the greater curvature of stomach, posteriorly up to the splenic surface and the anterior perineal space, and inferiorly along the transverse colon, suggestive of acute peripancreatic fluid collections. Coming to the next case, a 30-year-old male patient came with chief complaints of pain in abdomen, radiating to the back, few episodes of vomiting since 2 to 3 days, raised lipase, amylase, and CRP values. CCT imaging findings were as follows. There's evidence of peripancreatic fluid extending anteriorly up to along the lesser curvature of stomach and posteriorly reaching up to the splenic surface and the anterior perineal space. This is suggestive of acute peripancreatic fluid collections. Coming to the next case, a 38-year-old male patient came with chief complaints of pain in epigastric region, radiating to the back, and 3 to 4 episodes of vomiting since 5 days. The lipase, amylase, and CRP values were raised. The CCT imaging findings were as follows. Few non-enhancing areas were seen in the body and the tail region of pancreas, constituting less than 30% of the pancreatic area, suggestive of pancreatic necrosis. Next patient, a 42-year-old male patient came with chief complaints of pain in epigastric region and 1 to 2 episodes of vomiting since 4 to 5 days with 1 episode of fever. Serum lipase, amylase, and CRP values were raised. The CCT imaging findings were as follows. Few non-enhancing areas were noted in the uncinate process and the head region of the pancreas, constituting less than 30% of the pancreatic area, suggestive of pancreatic necrosis. Coming to the next case, a 36-year-old male patient came with chief complaints of pain in abdomen, nausea, and 2 to 3 episodes of vomiting for 2 to 3 days. Serum lipase, amylase, and CRP values were raised. The CCT imaging findings were as follows. A non-enhancing filling defect was noted in the portal vein, causing its moderate luminal compromise and seen extending to the right portal vein and its branches, suggestive of portal vein thrombosis. Coming to the next case, a 14-year-old male patient came with chief complaints of pain in abdomen, nausea, and 2 to 3 episodes of vomiting in 2 days. Lipase, amylase, and CRP values were raised. The CCT imaging findings are as follows. A non-enhancing filling defect is noted in the splenic vein, which is seen reaching up to its distal part, causing near total luminal compromise, suggestive of splenic vein thrombosis. Next case, a 33-year-old male patient came with chief complaints of pain in abdomen, nausea, and multiple episodes of vomiting since 1 to 2 days. The serum lipase, amylase, and CRP values were raised. The CCT imaging findings were as follows. A non-enhancing filling defect was noted in the splenic vein here, which was causing its moderate to severe luminal compromise, which is suggestive of splenic vein thrombosis. Coming to the next case, a 34-year-old male patient came with chief complaints of pain in abdomen, shortness of breath, and few episodes of vomiting since 4 to 5 days. Serum lipase, amylase, and CRP values were raised. The CCT imaging findings were as follows. The visual section of thorax in a patient of acute pancreatitis shows evidence of bilateral mild pleural effusion with passive utterance of underlying lung parenchyma, which is suggestive of systemic complication in a patient with acute pancreatitis. Coming to the next case, a 39-year-old male patient came with chief complaints of pain in abdomen, nausea, and few episodes of vomiting since 3 days. The serum lipase, amylase, and CRP values were raised. The CCT imaging findings were as follows. In a patient with acute pancreatitis, there's evidence of left-sided mild pleural effusion with underlying passive atheriosis suggestive of systemic complication in a patient with acute pancreatitis. Coming to the next case, a 42-year-old male patient came with chief complaints of pain in the epigastric region, radiating to the back, fever on and off, and 1 to 2 episodes of vomiting. Lipase, amylase, and CRP values are raised. The CCT imaging findings are as follows. There's evidence of free fluid noted in the interbowel region and the pelvis region, suggestive of ascites, which is suggestive of a simple systemic complication in a patient with acute pancreatitis. A 30-year-old next case, a 30-year-old male patient came with chief complaints of pain in epigastric region related to the back and episodes of 1 to 2 episodes of vomiting since 2 to 3 days. Serum lipase, amylase, and CRP values were raised. The CCT imaging findings were as follows. The visual section of abdomen in a patient with acute pancreas were as follows. There's evidence of reactive wall edema noted in the transverse colon and the descending colon, suggestive of reactive wall edema. These are my results in which two cases of acute peripancreatic lesions were taken. 2 of early pancreatic necrosis, 1 of portal vein thrombosis, 2 of splenic vein thrombosis, 2 of pleural effusion, 1 of ascites, and 1 of reactive bowel wall edema. Discussion. Acute pancreatitis is a dynamic disease with wide clinical spectrum ranging from mild self-limiting inflammation to fulminant pancreatitis with multi-organ failure. Early recognition of complications is crucial as these largely dictate patient outcome, the need for intervention, and mortality. CCD remains the cornerstone in evaluating complications, especially beyond several hours after onset, when necrosis and vascular events become radiologically apparent. Coming first to local pancreatic complications include pancreatic necrosis, in which differentiation from interstitial edematous pancreatitis is vital, as necrosis carries a significantly higher risk of infection and mortality. Next, peripancreatic collections. Acute peripancreatic fluid collections are common in the first 4 weeks. Ward-off necrosis may be seen in evolving necrotic pancreatitis. Next to pseudocyst formation should not be labeled before 4 weeks. Overcalling is a frequent pitfall in early CT reporting. Coming next to vascular complications, which includes splenic vein thrombosis, SMA thrombosis, portal vein thrombosis, pseudoaneurysms, which is most commonly involved in the splenic artery, followed by gastroduodenal and peripancreatoduodenal arteries, which appear as enhancing foci within the peripancreatic collections adjacent to the pancreas or hemorrhage. Gastrointestinal complications include bowel obstruction, ischemia, or fistula formation, which are usually rare. Systemic and extra abdominal complications include pleural effusion, ascites, ARDS, abdominal compartment syndrome, in which there is increased intra-abdominal pressure from massive collections, and ascites may be inferred from compressed IVC and visceral edema. Pitfalls in CT mutation, edema versus necrosis, misinterpreting poorly enhancing but viable tissue as necrosis, overcalling collections, labeling acute peripancreatic fluid collection as pseudocyst before 4 weeks, or missed vascular lesions, especially pseudoaneurysms if arterial phase is not carefully reviewed. Timing of CT is very essential. Very early scans less than 48 hours may underestimate necrosis. Practical approach, structured reporting checklists to maintain errors, to minimize the errors and ensure comprehensive reporting. A structured checklist is useful, including pancreas enhancement, necrosis pattern, how much percentage, duct status, pancreatic, peripancreatic collections, location of the collection, gas forming infection present or not, vascular complications, gastrointestinal complications, and extra abdominal complications if present or not, such as ascites, pleural effusion, systemic complications. Conclusion. Early identification of complication in acute pancreatitis is critical to improve the patient outcomes. CT imaging, when carefully interpreted using a structured approach, can detect subtle signs of necrosis, vascular involvement, and systemic manifestations before they lead to severe morbidity. Awareness of the imaging pitfalls and adherence to a comprehensive reporting checklist enhancing the diagnostic accuracy and guides timely intervention. These are references used by me for the paper presentation. Thank you.